Welcome everyone. Thanks for joining our Verdo webinar discussing Automation 1.0 to Automation 2.0. My name is Martin Prasad. I'm Director of AI and Technology Transformation here at Verdo. For the agenda, we'll set the stage with some background, i.e. the problem that we're facing across healthcare settings, across healthcare systems. And then we'll go into the response, Automation 1.0, as we call it, essentially building a foundation for areas that we can build efficiency, walking through some of the key principles, and what to look for when identifying areas that you want to automate. Then we'll make it real. We'll go into a demo where we use the OBSP, that's the Ontario Breast Screening Program use case, to show exactly how a very foundational workflow can be simply automated and limit that human intervention. Once we've built a foundation of automation generally, we'll start to discuss how that can be taken on a journey alongside us to Automation 2.0, which again, we'll define it. It's far more pervasive workflows based on clinical data and probably a little more impactful and proactive, but requires a lot more data. We'll do a quick demo to explain exactly what that means and how you get started. And then we'll open it up for Q&A. So with that, let's jump right into the content. The healthcare human resources crisis. So Canadian physicians spend 18.5 million hours each year on unnecessary administrative work. That's equivalent to 55.6 million patient visits. We especially started to see this during COVID and post-COVID, just the amount of burnout that's occurring as volumes go up with an aging population and really far too much time being spent on administrative tasks rather than providing care for patients. In a space where right now, hours upon hours a week per individual provider is being spent on these administrative tasks, while others look for family physicians, try to reduce wait time, so on and so forth. There's a clear gap for us to be able to solve as demand probably grows much faster than the supply of new resources in the short term. So with that being the crisis, the response, one of the responses, and one that we're very closely related to, is Automation 1.0. What do we define that as? It's a clinical workflow automation that refers to using technology to streamline and manage the various processes involved in care delivery. It involves automating routine tasks, reducing manual data entry, and ensuring that critical information is seamlessly shared across different systems. Now on the screen, there are four key use cases that sort of follow these themes. They're certainly not the only four. In fact, there is a very, very large group of these that exist, but we just want to highlight a few to, again, make this real. The first being smart scheduling. That's going to be the focus of this webinar in terms of the demo. The OBSP program will highlight how we've used smart scheduling to reduce the administrative burden. A second, which a lot of us are aware of and have interacted with in some form, is referrals and the digitization of it. PROMs and PREMs, for those of you who don't know the acronyms, that's simply reporting measures from the patient themselves. That could be an engagement survey. It could be periodic wellness surveys, so on and so forth. And then finally, the prescription reminders and refills, just ensuring that patients who are on medications that maybe require them at a specific cadence can access them easily. And so again, these are only four examples of a very large amount of use cases, but it just makes things real. So our take on Automation 1.0. Ideally, we automate a lot of the things that put pressure on the health system and maybe don't make the best use of healthcare resources, but we do want to make sure that they, follow certain principles. And so the three that we usually evaluate are One, it must improve the patient experience at all times. Two, it must reduce the administrative burden of healthcare staff. There should be no incremental. And this one closely relates to how we started this webinar, talking about the HHR crisis. And finally, it must be accessible. Anything that we introduce must increase the accessibility to healthcare for all patients. So before I go into the demo where we can take a look at how easily this can be done and create a foundation for further automation in the future, I just wanted to give a little bit of background on the use case. So it's based on the Ontario Breast Screening Program. And this program allows for women to be able to sign up for screening for cancer. And recently, they expanded the eligibility from 50 years old to 74 years old to 40 years to 74-year-old. And what that does is, one, it created a lot more demand. I mean, you've expanded the eligibility criteria by almost a third. And so now patients will spend that time to call into the program and book their appointment. And on the other end of that, there's a administrative staff member that would have likely needed to transcribe that information, book the appointment, and go through all of the steps to get that patient into the clinic. And so what we're hoping to show in this demo very simply is how we can limit that human intervention before the patient gets into the screening program, making it easier for both the patient and the provider. Okay, now that we've got the context set, let's jump into the demo. So the first thing you're seeing here on the screen is the patient view, probably the first thing they would interact with. And this is the landing page for appointment booking. Before I get into like the specifics, this link could be made available on patient portals. It could be made available on the website. It could be made available on a digital front door. The point is to get it out to as many people as possible, and it's easily accessible to anyone. Now, with the theme of accessibility, I'd like to highlight the Astral tool, which basically ensures that regardless of how you can interact or do interact with websites, we have tools that make it easier. So things like a screen reader for those who can interact with it visually, or those who simply just want to make the text bigger. And so just wanted to highlight how easy it is for anyone to really interact with it. Now, when you look at the screen, of course, everything seems very Virto branded. And I just want to make sure everyone's aware this is a demo. All of this is configurable. The branding, the colors, the logos, so on and so forth. Now, when we get into the actual content on the screen, you can see this is data that's pertinent to the OBSP program and anyone that's interested in signing up. It essentially highlights the eligibility criteria and any key information you need to know before the screening. As with the rest of the screens that are patient or provider facing, there's configurability. So in an effort to not repeat myself, just be sure that what you're seeing on the screen can be configured for your particular pathway. So now we're going to run through the demo. I will be Jane Doe trying to sign up for a simple breast screening. Now, what I'll do is I will start my booking. I've read through the criteria. I believe I'm a part of this I'm eligible for this program, and I'll hit start my booking. Because it's a demo, we've got one clinic set up and the single OBSP type appointment. I will attest to the information being correct. Now I'll choose my date. So before I get into actually picking that date, the next thing I want to highlight for everyone here is if you've interacted with pathways and enrollment, whether self-enrolled or otherwise, chances are you already have a native scheduling system, whether that's in your EMR or it's a platform you use. Outside of that EMR, we do know that those exist. We do know that you probably already have a workflow that fits them. And so we've integrated with many of our partners on either proprietary APIs or data streams so that it doesn't change the workflow for the provider or the administrative staff themselves. For example, basic ADT feeds, where we can look at the appropriate A messages and SIU messages, could directly feed the slots that become available in this calendar. For the purpose of this demo, I will show you the end-to-end, which includes configuring the slots available inside of our platform. But just know that that is just one way of managing your slots. Okay, so as Jane Doe, I would like to book an appointment today, February 7th. Let's go with 4 p.m. You can see the number of slots available left open for me to pick. Now I'm going to confirm my booking, and I'm going to fill out some of the images or some of the fields on this screen. This is configurable. So it allows us to collect all of the data that you would want prior to the visit. And while I'm typing, the thing that I'd like you to think about is this probably takes me less than 30 seconds. And it is resolving the workflow of a patient calling in, probably waiting on hold. And then a provider on the other side, or administrative staff on the other side of that, collecting that information, transcribing it, and entering it themselves. So again, we're replacing a fairly manual, time-consuming process for multiple folks with, as you saw, a few seconds. Now, before I probably won't fill out this section of the form here, but it's asking for my primary care provider. We're going to assume Jane does not have a primary care provider. And so we'll simply click that button and you can see that part of the form goes away. These forms can have that logic depending on the pathway and the type of information that you want to collect. Now I'm going to confirm that everything is accurate. And I do want this to come to my email as well as to my cell phone. So I'm just going to do both of those. Now that I've got all of the pertinent information to book the appointment, you can see now I'm able to confirm. Once I hit confirm, the appointment has been booked. All of the information on this confirmation screen right now is also sent to you via email, just to avoid jumping back and forth. We'll skip that step, but I can expect both in myself, like my text messages and in my email, I have this information, including what you need to bring, how early you need to be there, so on and so forth. In that email as well, I have the ability to go to the link where I can get further information, or I can cancel the appointment if necessary. So at this point, the only thing left for Jane to do is show up at the clinic. On the provider side, if I refresh this screen, what we'll see is Jane Doe is now booked for 4 p.m. on Feb 7th. Now, you'll see there are 4 panes here representing the statuses that we want to track. This is a simpler pathway for the purpose of a demo. These can become quite complex, and we track these patients through these stages of the pathway. Now, if I click into Jane, assuming Jane has arrived, she's booked, she's now arrived. I have all of the information that has been entered by her. I can confirm, and then I can interact with the staging by simply just hitting arrived, save, and close. And now if I refresh my screen, you can see Jane's moved over to arrived. Once Jane has been called in, her appointment is complete. Another way to interact with moving the patients across the pathway is simply just dragging the card over to the next stage. You can see down below here, the status has changed, and she has now entered the completed stage. It's a very simple tool to use from an administrative standpoint. And again, what I really want to highlight is it's a couple clicks to confirm and move the patient along their journey, which would have otherwise been a very manual process. And it builds the foundation for further automation in the process going forward. Now, to round out the demo, the next thing I'm going to show you is how we even set up the appointment slots. So in lieu of a native scheduling system, whether that be in your EMR or somewhere else, you can set it up in our platform. And so here, I'm going to click the OBSP appointment, scroll down, and you can see I can add all of the days, hours, slots, the appointments that I expect to have in that time slot, if it's 2, 10, 20, depending on how many we can manage, the expected time, and it takes care of the rest in that calendar view. We can also override that availability with exceptions down below here, which is where, let's say you're on vacation for a week, you can put in the start and time. If you want to get more discrete, let's say you want to block off some time for documentation purposes or some other clinical need, you could put in the exact hours. And so that would override the availability, and it would not show up as available appointments in the patient view. Okay, so as you can see, very straightforward demo that solves a pretty pervasive problem when demand is high, and in this case it was. And so now we've made it real. We've talked about a real world use case where this takes place. We want to bring it back to you and how you think about automation across your workflows. And so the way we think about it is maybe looking for workflows that require manual data entry by staff. In the OBSP example, what I want to highlight there is, I mean, someone was manually transcribing while another person, i.e. the patient, was providing that information over the phone. And so by way of just a simple solution, the patient can self-enroll with no intervention on the provider side. You can also look for workflows where patients need to self-enroll. And again, OBSP is a good example of that. Thirdly, workflows where the patients require appointment reminders. So stats show that just simple reminders prior to the appointment reduces no-shows by up to 50%. We've seen that with our partners and clients. And had I flipped across screens so you could see my email, what you would have seen is all of that information required for the patient to show up to their visit. And that would have been enough of a prompt to potentially stop one of those no-shows. Also workflows that are fax-based. Anybody that's in any sort of community or primary care setting has probably interacted with a fax system in some way, whether that's the referral itself or an e-prescription where the last mile becomes fax-based. And then finally, this is our segue into Automation 2.0, is workflows that do not produce reports. Again, you could start really simple. So if you think about the OBSP example, it's 4 stages. It's the appointment booking workflow. But at the end of it, we've been able to track the patients and how long they've spent in each stage. We've also been able to track the patients that no-showed by simply having the provider or administrative staff drag it over into the no-show status. At the end of this, we can evaluate the patients that are not showing up and start to determine why. And that leads into Automation 2.0, which builds on the foundation that we now have. But it starts to pull data from multiple care settings, from multiple value sets and schemas across the healthcare system to automate more complex, targeted, proactive, personalized, in some cases, workflows of the future. So let's define what that is. So moving from Automation 1.0 to 2.0, what we're looking at here is a technology that not only streamlines the workflow, but also enables proactive identification, stratification, and intervention for patient populations. For this to occur, you'd have to think about the patients that make up a cohort with common attributes. And that cohort with common attributes needs to be able to have an outcome driven by a specific type of intervention that we would like to automate. I'll go into some examples of that once I get through the demo of how that gets started. But the key here is for any of this to happen, we need data that goes far beyond maybe an administrative workflow and a lot of times becomes pervasive within the clinical realm. This includes data from multiple EMRs that have different schemas, making it very difficult to integrate, as well as free text. A lot of core data across patients is locked up in free text. What is not in scope for this webinar, but what we've invested in, is the upfront processes to take that data in various schemas, and sometimes either uncoded or using different terminologies, and normalize it to a Firebase format that is coded and structured so that we can do this type of analysis and we can start to stratify the patients. The technology that we've developed to accomplish that automates a lot of that normalization, which often in more of a manual setting could take months if you follow a traditional point-to-point integration. Again, we're not going to go into the nuts and bolts of how that data gets transformed, but we're going to assume that it has been transformed. And now I jump into Virto Connect, which is where we get to interact with that transformed data and start to identify the patients we care about, stratify them into cohorts, and that allows us to figure out what we want to automate next based on the outcomes we want to drive. So I'm going to flip to my Connect screen. And so what you're seeing on this screen here is a dashboard with a population of 1,000 people. It's a demo, and some key demographic information about them. Before I jump into how we start to go through analysis, what I want to highlight is that these are just tiles, and these tiles can be configured to isolate the things you care about when looking at a patient population. So we've kept it fairly simple for the purpose of the demo, but know that these tiles are easily configurable. So now that I have my population and some basic statistics on what they represent, I want to dig in. I want to figure out the patients that matter to me for a particular outcome. And I want to do that in a way that doesn't require me to understand, SQL and data schemas. Think of me as either a provider managing my patient population, my EMR, or more broadly at the health system level, thinking of the policies that need to be put in place. And regardless, I don't have that capability to dive into the data in a notebook or a SQL server. And so what we've done here is we put in a search bar that allows you to interact with the data in a very natural language way. So let's say, for example, I want patients with COPD and insulin. Obviously, that's maybe not the most clinically valid for everyone, but the point is these are the patients that I want to look at. And so you could see at the top here, that automatically parses the data into the key filters that I need, not the data, rather, the query, into the key filters that I need, and then parses the data to only provide the high-level statistics of this population. And again, we can highlight any of the key things you want here, including journeys. But more importantly, we can also surface the exact patient records that make up this cohort. And that's important because now it surfaces the patients in my population that maybe I want to build that intervention for. I stratified the patients or the cohort, and now I can identify exactly who they are and what needs to happen. Now, if I click on H Brown, for example, it takes me, there are various views. We could do a patient summary view. In this case, I'm doing a feature timeline view where you can see clearly where all the attributes that make up this patient record have been collected over time. And again, the automation of the integration across EMRs, HIEs, so on and so forth, make it easier for us to display this on a single screen. So I care about this patient because I'm looking at the stratification that has COPD. And so obviously I could analyze, their journey and the attributes they've collected over that time. I can also just find when they got COPD, when it was first diagnosed. And this timeline shows that it was diagnosed late 2018, August 2018. And here you could see I also have some metadata on exactly the type of concept that this is, as well as where it came from. And so this is just a high-level view of how we interact with the data to stratify our population and then build the interventions on top of it. So bringing it back now to our presentation, Once I've been able to identify that cohort and who that patient is in that cohort, I can start to automate what I do with them. Let's take a real world example of that. We all know that patients with diabetes, or if you don't know, now you will, they have their annual visits and they also have their quarterly visits. A lot of times those quarterly visits are not actually met. And that's because one, the patient may not know that they require them. And two, it's very difficult for the providers or the administrative staff that support those providers to find those patients in their population, reach out to them, and then probably follow a very manual workflow like the one that we replaced with the OBSP example to get them in quarterly. And so in a new world where we identified that patients that are diabetic, for instance, are patients that we want to bring in on a quarterly basis so that we are following best practice, we could simply find those patients with that diagnosis. And the automation would be to look up the patients that do not have an appointment within the quarter, automate the reach out to them, very, very similar to the reach out post confirmation of the appointment, with a link that allows them to book their quarterly diabetic visit. And at that point, it's a very similar workflow to the OBSP workflow. And now those patients are easily brought into the health system and following best practice, ideally taking a more proactive, preventative approach to future issues and outcomes that may arise. So that was just to make it real. The thing I want to highlight here is to make any of that happen, you needed to know the patient was diabetic in almost a real-time situation. And then you needed to do multiple steps of logic to get to the end state. And that's what we think, the growth journey with our clients and partners could be from Automation 1.0 to 2.0. So the benefits. The first is it enables automations across sectors of care. In the OBSP example, it's a point in time enrolling for the screening, but this could be extended far beyond that, post-screening. What happens next depending on the outcome of that screening? And that's where we really want to get to, so that we're not only just collecting data and retroactively reporting on the journey that goes beyond the appointment pathway, but we're starting to influence that journey. The second benefit is the ability to identify trends to enable proactive resource management. Again, if we're looking at cohorts that we've stratified and we know who they are, and maybe their outcomes aren't exactly where we need them to be, we now have the data that we can cut and analyze that, and we can figure out where the bottlenecks are. That's the first step in helping manage these resources and automating some of the things that maybe unlock these resources in a better way. And then finally, it's improving outcomes at scale with population health initiatives. Right now, we're in a world where we can build policies based on what we believe the best practices are, and of course, we want to follow those. But the feedback loop is kind of broken, and we don't know if we're always making the impact we hope, and we also don't know if we're focused on the right cohort or stratification of patients. And so that even goes back to Automation 1.0, where these processes don't lead to reporting that can be used downstream for decision making. And what we're trying to say here is, take those foundational steps, grow with the automation, and start to make more pervasive decisions, more evidence-based decisions on the populations that you actually want to build these interventions for in the future. And that's ultimately where we want to go with our clients and partners. So with that, I think that's kind of the end of the meat of the webinar. I want to thank you for joining, and we'll open it up for questions. We know that FHIR's largely not adopted, and there's a journey for health systems to get there. We don't intend to push FHIR down to clinical systems right now. In fact, in many cases, we act as a facade. That is what the InfoWay Connectathons and Projectathons, even in the US, attempt to prove, that we can take unstructured free text that is in a clinical SOAP note and normalize it into FHIR, which can then be acted upon. Now, of course, there are attestation considerations and a bunch of clinical workflows, but the mere ability of pulling data from proprietary schemas, non-FHIR based, including HL7, to FHIR is exactly what we intend to automate. And therefore, when that data is structured and in a FHIR-like format, alongside all the other point solutions that we integrate within a health system, we can now aggregate this data and interact with it as a whole. Great question. So yes, the answer is yes. The automations themselves right now are not AI based. Obviously, in a future world, if that is a value add because the workflows and automations are so dynamic, we would love to do it. But where the AI is primarily used right now is exactly in that data transformation. Now, what do we use? We use large language models, but we do not use its generative capability. And why do I mention that? Because a lot of the risk with LLMs right now, although it's highly mitigated at this point with all of the innovations basically weekly, is that it hallucinates, or you can't trace where certain logic came from or data points came from. And so we use the knowledge of these large language models to interpret free text and schemas that are proprietary in some way to normalize this data and put it into a FHIR format, but we also maintain the logic. So that's why it's not generative. We use the knowledge, but it's a non-generative output that we can interrogate and trace back to the source data. That is primarily where it's used right now. And from a testing standpoint, here's the reality. In healthcare, turning data of any type into structured coded FHIR data, that annotation does not exist at large. Even, as a company like ours, we track this pretty much daily, looking for these data sets. And so we actually work with our clients to annotate this data and come up with tests that they are comfortable with. And along that journey, we actually agree even on the performance metrics. AI has a different set of metrics that end users need to understand. So we work with our clients to be able to make those accessible to not just AI professionals, but clinicians or administrative users that need to use this data downstream. The short answer is yes. The short answer is we do have active projects that require this. I'm not going to go into specifics on the relationships we have with these folks, but I can tell you that there are active projects where data from some of these systems that are mentioned are transformed in some form or fashion and being used downstream or will be used downstream. The bottleneck for everyone, not just Virto, is there's so many layers to getting it to a point where we can orchestrate. So assuming, I'll give you examples with our clients, assuming that we do transform that data into everything I just said, coded, structured, FHIR data, how much trust can be put in it prior to attestation again? And how much change management is required for us to be able to trust it and act on it without any human intervention. And so this is why we think that there's like a natural journey that we've started to notice a trend with our partners, going from things that, are fairly easy to structure, very understandable workflows, not as pervasive in a clinical setting, and then building towards more pervasive, proactive, personalized care where we need those clinical data points, and they may not be as available as schedules. And a lot of times do require text extraction and things of that nature. But at that point, we've gone through this journey where you understand what we're doing with your data and the value of it. And so we can start to have these discussions at length. And that's how we get through that blocker. live projects that we have right now span from primary care agencies, I would call them, where they work with primary care organizations or networks to get them the data they need and actually offer automation as a service already. Other clients are health systems that have even invested in a data lake and have, dumped a lot of data from multiple massive systems, acute care systems, community care systems that house 90+ services. And then they need to make sense of it. They need to put all of that data together in a journey to figure out what needs to happen with these patients, where the focus needs to be in the health system. And so we've been able to normalize the data, aggregate it. We do some patient matching, nothing novel there. It's your 4 or 5 point match that a lot of people in the space would be familiar with. But then we offer the traceability back and the malleability with the data to ask it anything you want. And so I would say it depends on the use case. I mean, we do have clients that span from a primary care clinic or a specialty clinic or a screening clinic like OBSP, all the way up to entire health systems that house pretty much every healthcare service that you'd access. It's actually something we're working on quite a bit when talking to one agency in particular right now, where they build automations off of this free text. And our main goal is to feed the highest quality data to them. Now, depending on the level of pervasiveness and complexity of that automation, there are different levels of attestation and validation. We do have validation screens that our system administrators can use, where we kick out every single thing that we've extracted from that free text. And like I said, it's non-generative. So when we pull out diabetes mellitus from a free text as a condition, we actually keep the string index. So character 4 to character 26, let's say, and we keep the document ID, and we know exactly where that information came from. So we can evaluate whether that's correct, and we can evaluate all the peripheral data that augments that condition. And we present it in validation screens to our system administrators. Beyond that, we work with the primary care offices to present that data to providers so that if we do automate an action off of it, they can check to see exactly what data that automation was based off of and exactly which document it came from. And so we do actually have a feedback loop where if they disagree or something was just flat out incorrect, it can be flagged, and it can be flagged either at the provider level, which we don't expect as much of, or it can be flagged at the system administration level, both with their own experiences.